Right, I believe we are live and you should be able to hear me. What I would say is very good afternoon, good evening. Greetings, everyone, and welcome. My name is Craig Stewart. I'm a fellow cluster headache warrior, and I'm privileged to have assisted in bringing this live presentation to you this evening. Thank you for taking the time out. I appreciate how valuable your time is. And look, the number of registrations, I guess, reflects just a genuine interest in improving our understanding, treatment, and the outcomes for people living with cluster headache. We've got attendees joining from New Zealand, across Australia, and other parts of the world. And I think that in itself speaks to how important this conversation is. Cluster headache is a condition without borders. It's a global condition, and the need for better research and better treatment options is shared by all of us. I want to acknowledge just how important awareness of our guest speaker's work is for our community, the research that he will be presenting, particularly around patient perspectives and emerging treatment options. Look, it just represents a meaningful and important step forward for us. And while the clinical trial he'll be discussing is conducted in Australia, certainly this work matters to cluster headache patients everywhere. Before we begin, the presentation is being recorded and it will be made available after the webinar, so you'll be able to revisit it or share it with others who weren't able to be here. And at the end of the presentation as well, we will open the floor for questions. So if you have a question during the talk, please, Dr. Faraidoon is very open to answering your questions. Please place those in the comments or Q&A box, and I'll do my best to collate them and then present them to Dr. Haghdoost for discussion at the end of his presentation. Now, I'm bringing him up on screen now. Welcome, Faraidoon. It is my pleasure to introduce our guest speaker, Dr. Faraidoon Haghdoost, a medical doctor and researcher specializing in headache disorders. He is currently a research fellow in headache disorders at the George Institute for Global Health, and he also serves as conjoint lecturer at the University of New South Wales in Sydney. He completed his medical degree at the Isfahan University of Medical Sciences in Iran, and went on to earn his PhD through the University of New South Wales, where his work has focused on headache disorders, epidemiology, and clinical research. He has contributed to major global health research efforts, including work related to the global burden of disease, and has published across leading journals in this field. In 2025, Faraidoon was awarded, and get this, the Peter Goadspeed Award at the Australian and New Zealand Headache Society annual scientific meeting for Best Scientific Oral Abstract. His presentation focused on identifying gaps in the research and management of cluster headache through patient perspectives, and it highlights the critical need to better align research with lived experience of patients. Look, this combination of clinical training, academic research, and a clear focus on the patient voice, look, it makes his work particularly relevant to our community. Faraidoon, I would like to hand the floor to you.
Thank you so much. Can you hear me well?
I can hear you perfectly.
Yeah, great. Yeah, thank you so much. I really appreciate it for the opportunity and for the introduction. So I think I just give a little bit more information about myself, and I'm not sure if people can see the slides at the moment or not.
Not yet.
Yeah. So I'm, as you mentioned, I am from Iran. I'm from Kurdistan of Iran, which is in the west of the country. I did my training as a general practitioner and worked for a few years in Iran in different settings as a general practitioner. Then I always loved research, so I decided to do a PhD and become maybe a full-time researcher focusing on headache disorders. I have been doing research on headache disorders since I was a medical student 10, 15 years ago, but I just felt like I need to do it like in a full-time way at the moment. Then I came to Australia, did a PhD, my research for my PhD was focused on blood pressure medications for migraine and headache. And now I'm a full-time headache researcher. This is the job that I actually always wanted and I always looked for. And at the moment, I have the chance also, I recently started to teach medical students at the University of New South Wales, like a lecture on headache disorders, which is just 50 minutes to 1 hour lecture for year 3 medical students. But other than that, my work mostly is research. So if we could have the slides, then we could start. Thanks, that's great. Yeah, so today I want to mostly talk about the new research that we did in Australia with the help of many other headache clinicians and researchers in Australia, and not just Australia, actually, from US, Denmark, big team. And also I talk about the future trial that we are planning to do and we will start in a few months. So this study was published in Headache. It's the official journal of American Headache Society. And you see the list of people here, including Bob Wald from Clusterbusters in US. So for me, as I said, I like to have a career as a researcher, full-time researcher. And then for a researcher, the most important thing is the question, like what you want to research. So, and how you do that research. So I really needed to know like what we should focus on. And then I asked many people and we got together and we tried to find out the best topics to research. And one of them was on cluster headache, which we wanted to know what exactly we need to study in Australia, because ideally is you have unlimited resources and unlimited people to do research, then you can research everything. But now we know that specifically for headache disorders, especially cluster headache, and in Australia and New Zealand, we don't have that much funding. Like in the last 20, 30 years, we didn't have a trial funded by government on headache disorders in Australia, for example. So we need to get this funding, and then we cannot study everything. So we wanted to know what we should focus on and start research on, and something that is not just, because sometimes as researchers, we forget who we do this research for, and we just have ideas, we like to study them, but is it really something that people with the disease, which here is cluster headache, do they want it? Is it something that they want us to focus on, or they actually, based on their experience, which is usually they are more experienced than us in that specific disease. So is it something that they agree with, or we should study something else? So as some people here might not have cluster headache and just be interested in learning more about this, I just wanted to give some basic information about cluster headache, but it doesn't mean that I'm going to teach people with cluster headache what cluster headache is. So cluster headache is a type of headache disorder, which we call it the most severe pain that medicine knows. And some people ask, is it more painful? They have asked me this question when I said, is it more painful than gunshot? And I said, yep, for several reasons. One of them is we have evidence from US 25 people. Unfortunately, they had both cluster headache and gunshot, and they reported that they think the cluster headache pain is more severe, unfortunately. And also, it is something that you don't get that pain every day from like a gunshot. But cluster headache is like the pains can be several attacks in one day. You can have several attacks in one day for a few weeks, for a few months, for some people throughout the year. The pain that is very severe, it's people describe it in many different ways, like knife in the eye, like many different ways of explaining it. So we can simply and with confidence say that it is the most severe pain that medicine knows. But we have limited options for treatment, and that's the biggest problem. Like, why? Like, why don't we, for such thing that is that severe, why don't we have proper treatments, and what is happening here? One of the reasons is we don't have enough trials and enough studies on this. And why? We have several reasons here, but before that, I just want to say what trial is. When we want to add a new medication, a new intervention as a treatment into guidelines, be able to get it back from insurance, doctors be able to prescribe it, we need to do some research, which is called trials. Trials means that you have usually more than one group, two groups of people with the disease. You give them an intervention that you want to study, compare it with another thing. It can be placebo, it can be nothing, or it can be, for example, a treatment that we usually use, like verapamil or other treatments. So you need to compare it, study the new intervention in people with the disease, see the effect, and see that it is safe and also effective. Then you are able to add that to the guidelines and use it and prescribe it. But why don't we have enough trials for cluster headache? Generally, we don't have enough trials for headache disorders, but for cluster headache, we have very limited ones. And there are many, many different reasons. One of them is it is a rare disease, relatively rare disease. Compared to migraine, 1 in every 5 people in Australia has migraine disease. But cluster headache is 1 in 1,000. We are doing a big review to see there are some ideas that it might be even 1 in 2,000. We don't know. So let's say 1 in 1,000 people. So it's rare. The other thing is, like any other disorder, not everyone is interested in joining trials. It can be for many reasons. You don't have time. The trial is not in the city that you are there. You don't trust. You don't want to be studied. The intervention is something that you don't feel comfortable with. Many different reasons, and all of them make sense. Many people are not willing to join. So out of those 1 in 1,000 people, still not everyone can join a trial for many reasons. The other one is the nature of the disease. Cluster headache is a type of headache. We are talking about the classic one. You don't have attacks all year. You have attacks for a few weeks or a few months, then you don't have any attack till next year. So if you want to join a trial, you should be at the time that you have headache. Like, you cannot check the effect of a treatment if you are in the headache-free time of your cycle. So when you have the attack, you might not have time to join a trial. You might not be in the same place. There might be no trial. Like, when the trial is there running, you might have no attacks. So this makes it even more difficult. We have different types of cluster headache, which is called chronic cluster headache. It is all year. Like, these patients, these people, they have headache attacks all year. That's different. It is less common. But the typical cluster headache is the one that is, there is a cycle, cluster of attacks. Like, that's why they call it cluster of attacks, then no attack for a few months. And the biggest problem, like every other trial, is funding. Especially for a rare disease, it's difficult to get fundings from pharma companies. So usually you have to rely on government fundings. And government fundings, like in Australia, I don't know if you have heard about this before. Like, the chance of getting a grant in Australia on average is 5%. Like, any grant that you submit for all disorders, not just for headache, the chance is 5%. Like, technically you need 20 submissions, over 10, 15, 20 submissions to get one grant funded. And for headache disorders, maybe it's even less. So for all of these reasons, studying cluster headache specifically is really difficult. So, for example, funding, there might be a chance to convince some pharma companies, for example, for researching migraine more than cluster headache, due to the prevalence and being more people with that disease in the country. So we had a team that you can see the list, and this is growing. More people are in this team now. I asked them, and everyone kindly joined, and now we have this team that we want to together do more research on headache disorders, specifically cluster headache, because we believe that I'm focusing on all different types of headache disorders: cluster headache, migraine, and tension type headache. But when we wanted to start one of them to prepare grants and check, we were all thinking about cluster headache. We said, okay, let's start with cluster headache, but then after that, we might do the same survey for tension type headache, the same survey for migraine. But we all believe that cluster headache is the one that we need to start with. So, as I said, we all got together, we decided to study this, but then we needed a plan. So we all together, we designed a survey, and we wanted to check people with cluster headache idea, like opinions, what they think and what they want us to research. So the survey was designed on Qualtrics platform, and we asked adults living in Australia self-reported diagnosis of cluster headache. The reason Australia is because we wanted to apply for grants in Australia, and we needed this information and this data from Australia to convince them for funding. But maybe we could repeat the same study globally after this study, which was a very successful study. And self-reported doesn't mean that self-diagnosed. We asked them if you have cluster headache, and if they say they have cluster headache, we accepted that. But for the trial, if one day we do the trial, people who say we have cluster headache, then they will come in for interview, for checking the diagnosis, for checking the all eligibility criteria. But for this study, we didn't check the diagnosis, and it is the report of people. And I believe it is accurate. We had also one question that, have you been diagnosed by a doctor? And then almost everyone said yes. So the survey that we used had 3 sections. One of them was information about age, gender, and information like that. The other one was about the disease and the treatment experience. Like, how is your disease and how is the treatment? The other one was future trials. What do you want us to do? And will you join trials in the future or not? This part was the difficult part because, and by the way, this questionnaire was approved by University of New South Wales Ethics Committee, and ethics is always like very specific, and they have to make sure that none of even the questions is gonna hurt anyone. And I really appreciate what they do. So they check the questions, they check the whole process, and they asked us to revise sections. So what we had there was something that was approved by ethics committee, that this is proper, this is a good study to be done. So we didn't have budget for advertisement to go online, like Facebook ads, YouTube ads, and things like that. So we asked different organizations, different advocacy groups, doctors in the team, clinicians. We posted on our own social media. So all we got is just based on like a very organic way, using the connections and the support that we had, like Migraine and Headache Australia, Cluster Busters Australia and New Zealand, Headache Society. They helped us a lot by sharing in their newsletters, by posting the advertisement. So I think for a study in Australia, we got a good number, and we had a very actually impressive participation by people. So about 219 people started the survey, but some of them, they just started, and after the consent, no more information was there. 202 people had enough information that could be included in the study. On average, they were about 46 years old. 77% were between 25 and 54 years. 55% male. So this is something that we had 50-50 actually participation. And about 5% were Aboriginal or Torres Strait Islander. So we had good participation from, we had a good reach, at least, to different people from different places. And now we have more information I will share. For example, about 66%, 70% were from urban areas, but we had also participation from rural and regional areas. So some information about the disease, like their experience with the disease. About 70% had more than 10 years of cluster headache. So that is something, it shows that people with longer duration of cluster headache were more keen probably to join this study. It doesn't mean that like this is the people that are keen to join trials or studies in Australia, but this is our result that we got. We also have 70% people with episodic cluster headache, which means that they have headaches some months, some weeks, then no headache for the rest of the year till next year. But about 30% of the participants were chronic cluster headache, which in epidemiology, we see that it's about 5 to 10%, so less. So here we see that more people with chronic cluster headache joined the survey. Probably they are the group that needs to study more. They are the group who supports research more, or for many different reasons. And 85% reported at least one mental health condition, such as stress, 70%, anxiety, and depression. And 15%, only 15% reported nothing, and it's good. So this is also another information that, for example, helps us in designing future studies. We should check outcomes on mental health, like anxiety, depression, to see if the intervention that we use also helps with that or not, especially something like psilocybin that is approved for depression in Australia. So some research, they say that you have to exclude people with depression and anxiety for study with cluster headache or for research, which for cluster headache, first of all, it makes it impossible. If we exclude those people, we are excluding almost everyone. And the other one is maybe the psilocybin works on both conditions. And that's actually another big win if we study such medication and see more effect, like one treatment, two disorders. So here, about 30% reported that they have headaches almost every month throughout the year, which is somehow the definition of chronic cluster headache. About 30%, they said that they have headache on specific months in year. So this group, for example, they can plan for it, for joining a trial. They know that probably it's about, I don't know, January and February that they usually have headaches. But another 40%, they said they have headaches sometimes, but they cannot tell when. So for this group, for example, if they want to join trial, they don't know. So what we have to do, if we want to do a trial on cluster headache, we have to do all the screening, all the setup, ask people that they want to join the trial to come, even if they are headache-free. We do the screening, inclusion and exclusion criteria, checking them, and then recruit them, but wait, and tell them, okay, this is the thing, this is the study, you sign the consent form and everything, but this is for all trials, not just these trials. That's the hope for future trials in Australia and maybe in other countries. So be ready for trial. This is the information about the trial, but wait. Anytime your headache starts, start collecting data, like your number of attacks, different data, severity, and everything, and then call us, and then we can start. It can be psilocybin, it can be candesartan, which we also have submitted a grant to study candesartan for cluster headache to join a group in Norway. It's called Norhead. They are doing a trial there, and we also have submitted a grant. Maybe we can do part of the recruitment in Australia. So if Australian government funds the trial. So we can discuss the trial with the participants, with people, and then if they are headache-free, they just know what the study is, and then they join later. So this is why it makes cluster headache difficult to study. If you have a disease that you have always, then you just make plan for it. You say, okay, based on my calendar, I'm free next week or next month, I can come. But here, you have to wait for everything to happen. And then this is like a list of conditions that like stress, anxiety, insomnia. This is what people scored and reported. Depression, panic attacks, different things that they reported, which they are all important. They all shows the importance of researching cluster headache and shows that we need more inclusion criteria. For example, sometimes we say that they have to have no depression, they have to have no like different disorders, nothing you should have just cluster headache, which makes it impossible. So this data helps us to even maybe change the guidelines for clinical trials on cluster headache to say like, we cannot study just pure cluster headache. It's not possible. We don't have such thing. So about the treatment, about 85% are using acute medications. What does it mean? For treatment of headache disorders, we have medications we use when we have the headache, acute treatments, And we have medications we use to prevent future attacks, which we call preventive medications. 85% use medications that need prescription for acute treatment, like sumatriptan. 70% use prescription medications for prevention. And only 45% of all participants are actually seeing a neurologist. So this can be for many reasons. It can be because you cannot find a neurologist, there is no access, or it can be because you saw them, it was not, you didn't get effect, or it can be for many other reasons. So this is the data that we have. So we are reporting it. So here we see that about 70% are seeing a healthcare professional. Only 30% they are not seeing any healthcare professional. And we asked those 57 people why. And it was like because of financial difficulties, because of like 15%, 10% access, 50% self-treatment. They said we are doing self-treatment, so they are not going to see any healthcare professional. It's not just for neurologists. And time or not getting expected benefits, 40%. And those 145 people who are seeing a healthcare professional, 85% they see a GP, 66% of those people, like 45% of all, and 66% of those who see someone is seeing a neurologist. And then pain specialist, then physiotherapist, and others. I think these are really interesting data, and it helps us to actually know what's happening in Australia and where we need to focus and work on. Out of the treatments that they are receiving, 85%, as I said, they are using prescription medications for acute treatment, and over-the-counter pain medications like paracetamol, 80%. This one is the one that I'm very interested in to learn more about in the future. Oxygen therapy, only 50%. So that is something that we know that it actually is one of the good treatments for acute attacks. But why only 50%? Is it because there is no access, which usually is the case? Is it because we don't know, like doctors or the patients, they don't know about it? Is it because it's not working? Why only 50% for something that we think is more effective than 50% like of the times? Then about 55% prednisolone. It's good to know about the people experience actually about the oxygen if they are in the call or later. Even if people they don't want to ask questions now or send comments, I'm very available. They know they can find my emails. You can share my email with them, and they can actually contact and share their experiences or comments or support or help, advice, especially later about the trial, what they think we should do or not do. So nerve block, 37%, medications for prevention, 75%, and lifestyle changes and other treatments that you see here. So we asked, okay, overall, because we couldn't have many questions to ask. Some people say, why didn't you ask questions about this and that? Because we had more questions, but it was long and people would get tired and not actually do the survey. So we had to make it feasible, this study. So we asked them one general question: how do you rate your treatment in general? So we see that only 6% reported very effective. 32% they said somewhat effective, 11% not at all effective, 24% somewhat ineffective, and about 30% said so it works sometimes, it doesn't work sometimes. And the problems are usually like effectiveness, 77%, they said like it's not working, that's our problem with the treatment. Side effects, 54%, cost, 53%, and access, 40%. So we asked them, what should we research? Like rank these options that you have. Most people selected researching why cluster headache happens, because we don't know. Like, to be honest, we don't know. Like, we have ideas, but why someone has cluster headache, what happens? And also studying more effective treatments. So these two at the top are actually now what we are focusing on. So checking new treatments, and if we can, during trials, checking how this works. And if we know how it works, maybe we can know what's the reason. For example, if we have funding during the studies, we can do imaging and see what is changing before and after the intervention in those who has effect. Then maybe we can see what part is actually in the brain is responsible. For example, different way of studying that. Then people want educating doctors and public. After that, improving diagnostic methods, enhancing awareness and education, identifying specific triggers, and so on. Something that I forgot to say, like cluster headache is, for those who are here without like experiencing this, on average, it takes about 8 to 10 years for someone with cluster headache to get diagnosis. Like these people, they have the disease. They just go to different doctors and no one knows. Someone says you have sinus problem. Someone says eye problem, teeth problem, like many, many different things. And this is evidence-based. That evidence means based on many reports. 8 to 10 years since the beginning of the first symptom till they get the diagnosis of cluster headache, which that makes it even like more difficult to manage, because how do you manage something that you don't know you have, or no one knows that's the case? So, but even with all of those things, people still ranked understanding the underlying cause highest, and then developing more effective medications. So it doesn't mean that improving diagnostic methods is not important. It means that those are really, 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 really important, and then they have been ranked up there, but they are all really important. Then we said, if we study a new medication, what do you want us to check to see if it works? So the top one is the pain severity. Like if you are studying a new intervention, check how effective it is on the severity of our attacks. Is it reducing the attacks or the severity of the attacks? Then the next one is number of attacks. Like we have 10 attacks in 1 week. Will it reduce it to 5 to 3 attacks in 1 week? Then overall well-being, duration of each attack, number of medications. So we are using actually this data for our trial design. And based on international guidelines, number of attacks is the main one that you need for especially using it later for adding the new intervention to guidelines and things like that. But we are also checking other interventions, specifically pain severity will be one of our outcomes that we will be checking. So this is, I think, one of the main slides of the main findings of our study. We asked people, 202 people in the study, if we do a trial, will you join? 126, 62% said yes. And 26 people mentioned maybe. This is important because sometimes when you apply for grants, they said, okay, this is rare. How do you know people will join? Sometimes people, we say that we like to do trials, but we don't know if we can get support from the community. So here, this question is general participation in future trials. And it shows that people with cluster headache in Australia are actually supportive of trials, trust it. And if you start it, definitely it should be a good trial with ethics approvals, with an intervention that makes logical. But if you design a study, people are happy to join if this study is a well-designed study. And then we asked them, okay, then what intervention do you want us to study? We see that if we just look at the very interested one, the dark blue, psilocybin was the number one. If you look at the very interested, we see that combination therapy is actually the top. So psilocybin received the highest score, then combination, which means that mixing different interventions together. It makes sense because the disease is very severe. The duration is short. Sometimes it's like 1 month for some people. You don't have time to check something go through all of the pain for 2-3 weeks, then select another intervention. So maybe combination actually from the beginning might be a better option actually. So that's something that is good to study. Sometimes for some, for example, for blood pressure management, now there are new evidence that instead of starting with one intervention, one blood pressure medication, because that's the guideline, you start with one, if it doesn't work, increase the dose, then make it 2, increase the dose, then change it to 3 different types of blood pressure medications. But there are new evidence that says that just start with the 3 at the beginning, low dose. Like that's might be even better, and then save a lot of time, save a lot of lives. So here we might be actually thinking about this from the beginning. Then CGRP medications, which calcitonin gene-related peptide medications, the new treatments that we have for migraine, which some of them have been studied for cluster headache, some worked, some didn't. So people also selected that, and other interventions, medical devices, biofeedback, and lifestyle changes, and other. So that was the study. One question that I always receive is, why psilocybin? Like, after especially receiving the grant, I have been asked this question: why not this? Why not that? Why psilocybin? So the main answer that I have is because people with cluster headache ask for it. So that's very simple answer. That's something they believe it works, and they ask us to study. But there are other studies also out there for psilocybin for cluster headache, some surveys and some small trials. For surveys, we have an interview which they found that 84% reported that using psilocybin stops the attacks. And 52% reported that it stops the whole, like the bout, the whole period of cluster headache, which means that one single dose stopped it till next year. That's a report from some people. Then another survey by Cluster Busters showed that 64% reported like when they had attack, after using psilocybin, the attack totally got stopped or like somehow stopped. And 71% reported that it prevents future attacks. Another study showed similar results. These ones on the left side, they are surveys and questionnaires. We have 2 small trials, which actually the investigator of both trials are part of our team. Like we invited them, they joined, and they actually helped us a lot. One in Denmark, which they had only one group. They included 10 people with chronic cluster headache. They knew that they are receiving psilocybin because it was only one group. And then they gave them psilocybin. It was per kg, but overall we can say about 10 milligrams of psilocybin in a few doses, like every 5 to 7 days, 2 to 3 doses. And then they found that about 3 to 4 attacks in 1 week. They have a reduction of 3 to 4 attacks in 1 week after using psilocybin for a few doses. Then another trial in US by Schindler et al. They had 2 arms, compared psilocybin with placebo. They had only 8 participants in each group, so it was a very small study also. But they found that about 3 attacks per week reduction when they compared psilocybin with placebo, which means that, let's say, in the group that they received placebo, about 2 days reduction in 1 week. In the other group, about 5 days. 5 minus 2 was 3. About 3 days more reduction in the group on psilocybin they found compared to placebo. It was not significant, but the sample size was very, very small. So 3 days per week attacks, 3 days per week reduction in attacks is actually clinically good. If we can do something, that's amazing. But when in a trial design, you see that it can be by chance. So you usually need a higher sample size to be able to statistically say that this finding is good. And if we repeat the same study several times, we get the same result. When it is not statistically significant, it means that this time it was like that, but there is a chance next time you repeat it, you might not find the same result. But these studies are actually giving us a lot of information, including, like, if we also include the results from our survey and what people during like different advocacy groups talk about, it gives us enough information and enough background data to study psilocybin. I think I'm going a little bit over time, so I'm trying to. So we finally, after several applications, we got a grant to study psilocybin for cluster headache. And these are the interviews that we had and the reports that there are available online. The original plan was to have a big trial, 5 years trial, and study the efficacy. And by the end of the trial, we'll be able to answer this question, if it works or not, because both are informative. Psilocybin works, we can change guidelines, we can add it to the list of options that doctors have. If it's not working based on a big trial, then we can tell people it's not working. So maybe we should look at something else. So both are very good information. But what we got funded was for a pilot trial, which is a 2 years trial with a smaller sample size. And it's mostly, we get this answer that if it is possible doing such research in Australia. And second, if we get the sample size that we look for, we can also answer the question if it's effective or not. But then if it's effective, we need a bigger study to prove it. So at the moment, we are looking for 40 participants, hopefully, 20 in each group. But it all depends on the design, the budget, and many other options that I talk shortly about them. So I would just like to quickly talk about the design of the trial that we have in mind. So we will have 40 participants, hopefully. And this hopefully is not just based on if people with cluster headache want to join. It's about a lot of things that if it helps us to happen. So we will have 40 people, and then we divide them by chance into 2 groups. One group receives 10 milligrams of psilocybin once per week for 4 weeks, which means that 4 doses. And these people, they don't go home to take the medication. They come to the center after checking the blood pressure and pulse rate and data like that. They receive the intervention and they stay there for 4 to 6 hours. And they will be under supervision of a nurse and a doctor available there. And if something happens, we have access to like medical support, which usually 10 milligrams is safe generally, but there is it will be done in a very controlled environment. And that part actually makes this trial expensive because we need the whole setup. We need the room, the people who take care of the participants for that time. And then after that, they have to go home with the help of a carer or someone. They are not allowed to drive. So 10 milligrams is not that high, like 25 milligrams. That is like a very strong psychedelic effect, but it's also not like 1 milligram, 2 milligrams that you don't feel anything. So we expect some psychedelic effects, which means that it depends. For some people with 10 milligrams, nothing. With some people, very strong reactions. We don't know. Like we know it is depending on, we don't know about that specific person. Like, but the first dose tells us then they have 3 more doses. And we will have all of these things prepared, training that what's going to happen, how it's going to be, if something happens, how to control it. And we expect some psychedelic effects there, but for some people, it's different than others. So the second group, the plan, this is the original plan, to compare it with placebo, which means that they receive 4 weeks of placebo each time. They don't know if it's psilocybin or placebo, but they still have to come, stay in the center 4 weeks, once per week, stay there 4 to 6 hours, and it's placebo. So something that here is, first is, there is a high chance people can tell that this is not psilocybin, because there are some effects probably with psilocybin. And then, look, we have this evidence that we don't need the psychedelic effect, like visions and things, to have the cluster headache reduction effect. So some people have 0 psychedelic effect. They don't feel like they had anything, but the cluster headache is gone. So that's also another interesting thing to study. Some companies are making psilocybin that has 0 psychedelic effect. And it's just for cluster headache psilocybin. They are working on that. So yeah, but the group in placebo probably can tell, and they have to stay there for 4 weeks, come for 4 weeks to the center. The other problem that here is, how about them? Like, this is the question that when we had focus group sessions with people with cluster headache, they were like, okay, then we come there and then that's it. What if we go into the control group? So then the grant that we applied, we have decided that to add this section. After 4 weeks of control on placebo, then we offer those people the actual intervention for 4 weeks if they want and if they still have headache. There is a chance after 4 weeks the headache is gone because of the nature of the disease. But if it's still there, and if they still want it, we offer them this 10 milligrams 4 weeks once per week. We still collect data for that, follow them. Everything will be done properly in the study setup, but the comparison will be done by end of the first 4 weeks, comparing psilocybin with placebo. But those groups, they still get the intervention. So this is something we explain to the participants, and we tell them, look, you might be in any of these groups. It's by chance. So if you're okay with that, this is a big help for like cluster headache research, cluster headache science, and also you have this option for later. But what we thought about that was, yeah, as I said, they will be on proper supervision during 4 to 6 hours. That's also something that some people were worried about, because it's logical to be worried about joining such trial. But we tell them that there is supervision and you will not be like left alone, or you are not going to go home and take the medication, take the intervention. But this is the second design, which probably this will be what we want to do. So one part of this meeting is to get feedback from you, like everyone, to help us to have a proper design, because I'm working on the protocol. We will start having the sites and submit for ethics and everything. So we need the proper study design in place before applying for all of those. So the trial design that we feel like we should do actually is this. We have one group. These two groups are by chance. Randomize them by chance to one of these groups. And then one group receives 10 milligrams 4 weeks per week. Then the other group waits 4 weeks, like nothing. You don't need to come to the center. You don't need to receive 4 doses of placebo. Here you know which group you are in. One group is on psilocybin. One group is waiting. Psilocybin 4 weeks, waiting 4 weeks. Then after 4 weeks, you join the psilocybin 10 milligrams 4 weeks once per week. Again, the comparison ends at the end of the first 4 weeks, comparing 4 weeks of psilocybin with 4 weeks of waiting, 4 weeks of just doing what you always do. And then with this, we have a control group. We don't need people to come to stay in the center 4 times on placebo, which they feel it. And also, they still receive the psilocybin at the end of 4 weeks of waiting. But they have to collect all the data during these 4 weeks of waiting, because we compare that 4 weeks with the actual intervention. But they still have the option to receive the psilocybin. This is the second design, and we probably use this design. So this is the important thing, is you need to be in the right place at the right time for this trial. The thing is, at the moment, I'm working on having different sites in Sydney, Melbourne, and Brisbane. But probably I can say definitely for this trial, we cannot have a site in Perth. So if someone is there, that's the difficult part. So they either have to come to this side of the country, or they don't have the chance to join the trial. That's why we want big trials. We want to bring trials to Australia. If there is a trial in US, Australians have no chance to join. People in New Zealand have no chance to join. If we bring trials to this side of the world, then actually in some books that are about cluster headache, one of the treatment options that I see they add to the treatment list is joining trials. But in some countries, there are more trials. In some countries, there is no trial. So hopefully we can have sites in Sydney, Melbourne, and hopefully in Brisbane. But again, the trial will start in 2 weeks. Like the funding starts in 2 months, the funding. And we need a few months to prepare the whole study setup. And then probably the recruitment starts by end of the year. And then we have about 12 months to 14 months recruitment. Because the whole trial is funded for 2 years. So there are people that during that 12 months might not have any headache, or might not have time to join, or for any reason they cannot join. So that's something that hopefully with all of these sessions, with preparing early, providing information, early screening and everything before the start, after ethics approval, before the recruitment. So maybe we can increase the chance of this trial. And if it's successful, which means that be able to do it, have enough participants, and somehow show some data on efficacy, then we probably can do more trials in Australia. And hopefully, sometimes with just 20 participants in each group, we can show very dramatic effect. So that's something we don't know, like how psilocybin is going to work in this trial. So that's one challenging part. So yeah, in summary, just to summarize, people with cluster headache use medications, like prescribed medications for acute and prevention treatment. Over half of them believe that the treatment is not good enough. Only 6% believe that it's very effective. Patients are keen to join clinical trials, and most are interested in interventions like psilocybin and combination. And we need the support of everyone, especially, I was telling Craig about the trial, even if we don't have enough time now, even if later, I like questions that I don't have answer for, which means that I need to go learn. If it's about the design of the trial, it's good to know something now before later when we are in the trial and say, oh my God, we didn't know this. So if you ask me questions or send me comments or ideas that helps us with study design, that would be very, very helpful and appreciated. And yeah, we need everyone's help for doing this trial and more trials in Australia and like hopefully globally. This is my information, and that's my website. You can get a lot of information about me, my email address, and please contact me if you have any comments, questions, or advice. Thanks.
Thank you so much. What an excellent presentation, Dr. Haghdoost. I, on behalf of the community that has joined this evening, just want to firstly say thank you very much. We did go a little bit over time, but we do have some comments I think would be worthwhile kind of reading out from people. Just Yuri was joining us from Europe. Yuri, we will definitely have the recording available for you to look at. I know they've had a big couple of days. I believe a few of the cluster headache crew actually got together. So no doubt they've had a bit of fun. Kirsty from Cairns is just saying that you seem to have such passion. So she's just saying thank you and best wishes. Sean was just asking about the study in Norway, but I see that Pete McCormick has replied candesartan. I'm not too sure about that, but
yeah, the candesartan is a blood pressure medication. It's in the guidelines for prevention of migraine, and we have good studies that generally blood pressure medications reduces headache. And then now in that study, they went to in Norway, they went to study candesartan for cluster headache. They have two studies, one for episodic and one for chronic cluster headache. And it is running. I think it started. So maybe if they have cluster headache, they can contact them. I think if they search, they can easily find information about them. But here in Australia, we are waiting for funding. So not yet.
Kirsty says, as a future question for the end of the session, I'm about to start HRT for the dreaded menopause. Would this exclude me from participating in the trial?
I don't think so. Yeah, so we will have like the whole exclusion and inclusion criteria available when we have the protocol ready and the ethics approval. But depending on if it's new, if they just like, for example, in the last few months they have started, that might be excluded because we need it to be stable. But if it's like in a stable dose with stable condition, yeah, I don't think it's a problem.
Okay. Yakubu, and forgive me if I've pronounced that wrong there, but he says, Dr. Faraidoon, the third research priority is educating doctors and the public. Could you expand more on the education needs that this speaks to?
Yeah, thanks, Yakubu. That's a great question. So, for example, one part of education is me teaching medical students, year 3 medical students, about headache disorders. And I have heard from patients that, for example, they have been to emergency departments. They have told the doctors that they need oxygen, and they actually didn't accept that idea. Or, for example, how to use oxygen, or, for example, how to diagnose cluster headache. So yes, there is a lot of things that we can do, and I think it's getting better in training future doctors, in training medical students, and also like the family of people with cluster headache, colleagues, like managers, workplaces, that cluster headache is like a real severe condition, and some people might not actually accept it. Many people, they don't accept headache as a very important thing. They just say that it's just a headache. Come on. For example, I cannot come simply to a party because I have headache. It can be migraine or it can be cluster headache, but people say, come on, it's just a headache. They cannot accept you not going to a party or not going to work because of just a headache. Yeah, so there is a lot actually we can do for education.
There was a number of comments in and around oxygen, access to oxygen, cost to the supply of oxygen. $500 a month is, like, it's not to be understated how much that would eat into your wallet if you were needing that every week. But like I said to Faraidoon before we went live today, this week's been a tough week for me. Cluster Headache Awareness Week of all weeks. And so I'll be using a little bit of oxygen as well myself over the coming little while. And it's important. I think if people are watching and they're in the throes of cluster, do everything that you can to get access to oxygen. It's just such a powerful tool, not only to abort the attacks, but the other thing that came back with the attacks for me this week is just that sense of helplessness, of hopelessness, of, oh my God, my life's like, what am I going to do? How am I going to fulfill my obligations to my family, to my work? And it's as soon as you kind of get access to that oxygen and you have that 5-minute abort, you're like, I'm going to be okay. I'm going to be able to navigate this. And the other thing about our community, Faraidoon, I mean, I reached out to a couple of people that I'm close with in the cluster headache community. I've had so many check-ins over the past couple of days from them just to say, you're all good. We're a caring bunch, and I'm so thankful in some ways that I met these people, albeit through the condition. I've got Lisa who's asking, she's down in Tasmania, will the trial be available across all of Australia? So I think you answered that, but maybe she's just...
Yeah, I don't think so. But if someone can travel, actually, so they can join the study if they are in the cities that we have the sites. But at the moment, I don't think we can have a site in Tasmania based on the current budget and design.
Gillian was saying, are you working with any of the New Zealand researchers undertaking psilocybin trials, although she believes here it's more for treatment-resistant depression?
Yeah, so I have connections with neurologists there, but not with psychedelic researchers. But we are open to all connections. And hopefully, if the future trial, the bigger one, we can get fundings for that, maybe we can have also sites there. So yeah, we are open for any connections.
Pete McCormick has just made a note there. There are two very active, very helpful people in the Australia and New Zealand Facebook groups that will help people get oxygen. They work for oxygen suppliers and they are aware of cluster headache. So if you had questions in and around access to oxygen, I would encourage you to make a comment in the Facebook group there, and I'm sure one of them will reach out to you. Faraidoon, from my perspective, when we talk about trials, we often hear researchers talking about primary and secondary endpoints. And so I'm just wondering, like, what is the measure in this trial to say it was successful or it wasn't? What would that kind of look like?
Yeah, so the main outcome, the primary outcome for this trial will be, for the pilot trial, the main outcome is feasibility and acceptability, if it's going to work. But in terms of efficacy, the main outcome that we have is reduction in the number of attacks in 1 week, comparing the two groups. So if we have a significant reduction, that's our primary outcome. But we also have a lot of many secondary outcomes, as you mentioned, like severity, scores for depression and anxiety, number of medications they use, the number of the duration of each attack. Yeah, we have a lot of different outcomes.
That was indeed something I was going to ask, that second part, as to other measures of outcome, particularly in and around that mental health burden. And can I say, when you were talking to those slides with the statistics, that was super hard for me to listen to.
Yeah,
it just means that there are a lot of people out there suffering through attacks with inadequate access to medications. And it's just heartbreaking, honestly.
yeah.
I think we're going to leave it there. Any other questions? I think we could collate them as people rewatch the presentation and maybe just want to articulate those. We can get them over to you. Thank you so much, Dr. Haghdoost. We really appreciate your time and your efforts. It's so refreshing, and it was reflected in the comments there that you've listened to our community and you're trying to effect a trial that reflects some of our feedback. So again, on behalf of everyone, thank you for being here and thank you for the important work that you're doing.
Thank you so much. Thanks for inviting me and for organizing such a great session. Thanks. Thanks, everyone. Bye.